All right, sounds good. Thanks everyone so much for joining today. Leafa should have sent everyone who registered the CME handout information as well, so you should have that too. But we'll go through these slides really briefly. So you text the number 66612 to the number on the screen by 1 p.m. tomorrow. That will get this added to your evaluations, and then you just have to complete the evaluation online at Beaumont Cloud CME by December 3rd to get credit for attending the course. Next slide. And like our other meetings, we are able to offer CME for AMA PRA Category 1, Nursing CE, Pharmacy CE, and Dietetic CPEU credits for being a part of this lecture. And then our disclosures really briefly, Dr. Ashman, who's the course co-director and helped develop this materials, has stocks in publicly traded companies or stock options, Abbott, AbbVie, Johnson, Merck & Co. And with that, I will hand it over to Dr. Griauzde. We are so lucky to have her here speaking about this topic. She's an expert in this space, and it's nice to be able to get her perspective on these weight loss medications. With that, I will hand it over to you, Dr. Griauzde.
Thank you. Yeah, somehow my mouse is not like advancing, so hopefully that issue resolves. But yes, thank you all for attending today. So I work clinically at the Ann Arbor VA. I do primary care, and then I also run our weight management and metabolic health program where we use a lot of anti-obesity medications in conjunction with specific lifestyle changes. So as we go through, feel free to put questions in the chat. I think Jackie's going to monitor the chat. If there are questions that can wait till the end, we'll answer them at the end. If there's questions that are sort of, timely and relevant to the content on the slides, we can certainly pause. Also, feel free to unmute yourselves and just jump in if something's not clear. So this is a pretty big topic. This could easily be 2, if not 3 lectures. So today, my goal is to kind of cover 4 topics in maybe a high-level way. There are some additional slides at the end of this talk. So if we circulate the slide deck, there's more information and more references. And I've tried to kind of create some highly referenced slides so that you can, guide your learning if in the future if needed. So the 4 topics for today include, an overview of obesity as a chronic condition. We'll discuss the mechanism of action, efficacy, and safety of the newer incretin mimetics. We will discuss the role for older anti-obesity medications, and then we'll end with a case example. So I think we are all well aware that we're facing a public health crisis, that rates of obesity are higher than ever, and they're continuing to rise worldwide, and that we have, a close pathophysiologic link between obesity and type 2 diabetes. Clinically, we use BMI to define adult weight status. Generally, a BMI above 30 is consistent with obesity, though lower cut points are used for adult populations. Even though this is our common clinical measure, it doesn't really tell the whole story. We know that when we look in a population of patients or a group of patients with obesity, there are relevant and sort of consistent associations with elevated BMI and adverse health outcomes, as well as the incidence of certain chronic conditions such as prediabetes and type 2 diabetes. However, at the patient level, we know that BMI is an imperfect measure and that we can find individuals with metabolic health and metabolic dysfunction across the full BMI spectrum. And we can make sense of this heterogeneity in obesity and its consequences by thinking about the distribution of body fat. Visceral fat or ectopic fat, fat that's stored in the organs such as the pancreas and liver, exert more cardiometabolic harm than subcutaneous fat. And that in the case of type 2 diabetes, ectopic fat, fat in the liver and pancreas, increases the risk of type 2 diabetes regardless of a patient's BMI. And so if we look at this picture on the right, we can imagine that this first individual where there's a lot of red shading in the abdomen indicating high visceral adiposity might have type 2 diabetes at a relatively low BMI of 25, whereas the figure on the, the second figure shows less visceral adiposity, more subcutaneous adiposity, and this individual may be less likely to have type 2 diabetes despite the higher BMI. So I think that this has important implications when we discuss weight with our patients. When we are approaching weight management, we are never targeting a specific weight or really a specific BMI. We're not targeting a normal BMI. Rather, the goal of weight loss therapy, I think it's sort of eloquently listed on the bottom of this slide here, but really the goal of weight loss treatment is to prevent and treat the complications of obesity and to enhance health and mitigate morbidity and mortality. It's relevant that as little as 5% body weight loss is clinically meaningful. Among patients with prediabetes, for example, 5% weight loss can prevent progression to type 2 diabetes. Greater weight loss may be needed to see improvement or resolution of other health conditions, but certainly weight loss of 10% up to 15% can improve glycemic status among patients with type 2 diabetes and reduce the need for medications. And so weight loss can really, or percent weight loss can really be considered the biomarker target for effective weight management. So for other chronic conditions like type 2 diabetes, we have biomarker targets such as A1C for hypertension, blood pressure. And so for weight management, we should think about percent weight loss. Now, there's a lot to say about this topic because obviously calculating a percent change is a bit trickier than just looking at an absolute number like A1C, but I think conceptually it's helpful. When we're approaching weight management, we want to kind of identify the baseline weight, what are we considering the patient's starting weight, and then look at a relative percent change to that stated baseline. Anti-obesity medications are one option to support weight loss. We can't forget, I mean, right now we are sort of in a pharmacocentric phase of obesity management, but of course there are non-anti-obesity medication options, including lifestyle change, bariatric surgery, etc. But anti-obesity medications, of course, are growing in number, and patients are interested in these therapeutic options. They are indicated for patients with a BMI of 30 or for patients with a BMI of 27 and at least one weight-related chronic condition. Patients should have tried and had non-achievement of weight or health goals with lifestyle change alone. And anti-obesity medications can also be considered in individuals who have had suboptimal weight loss or weight regain after bariatric surgery. Before starting an anti-obesity medication, it's really imperative that we counsel patients that these medications in general, and we can, talk a little bit about maybe exceptions to this rule, but in general, these medications are intended for long-term use, and they are intended to be used in conjunction with lifestyle change. I always sort of explain to patients that there is no medication or, oral medication or injection that is going to support weight loss in the absence of lifestyle change, typically, dietary change being the primary contributor in that case.
Dr. Griauzde, we have in the chat. Yeah. Is high blood pressure one of the obesity-related conditions?
Yes.
Great, thank you.
And that, generally, so each of these medications has sort of different stopping rules. And if you look in the package insert, you can see that some say the meds are effective if they support 3% weight loss, some 4%, some 5%. I think, 5% is really a clinically relevant target. I think generally, if somebody is losing less than 5% weight loss after 3 months on max dose of any anti-obesity medication, that would be an indication to stop that particular agent and try something else. So let's talk about the incretin hormones and these newer anti-obesity medications. What are incretin hormones? These are nutrient-stimulated gut hormones. They stimulate insulin secretion in response to a meal, so they're sort of considered smart secretagogues. They secrete insulin when it is needed. And there are two hormones of interest, glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide, which is abbreviated conveniently GIP. Now, these hormones have multiple actions in the body. Here, this slide is, highlighting the role of GLP-1, which really has 4 key actions. As I mentioned, it increases insulin in a glucose-dependent way. It decreases glucagon, so there's less glucose released by the liver. It delays gastric emptying, so it promotes feelings of satiety, and decreases appetite, leading to an overall reduction in caloric intake. And there's some overlap between the mechanism of action of GIP with GLP-1. Key differences: GIP acts directly on the fat cells or the adipocytes and increases glucose and triglyceride uptake and actually increases triglyceride storage. And every time I present this slide, I always feel like I have to acknowledge that I don't quite understand how that particular mechanism relates to its sort of potent weight loss effectiveness, but I think there's a lot to be learned. Native incretin peptides have really short half-lives, which has limited their therapeutic potential and really gave rise to the development of these receptor agonists. And these medications have been around for a long time. Exenatide, I think, was FDA approved for type 2 diabetes in 2005. And the medications on this slide, shown in bold, have separate, and some of them, in the case of tirzepatide, very recent FDA approval for weight management in the absence of type 2 diabetes. So I'm going to focus a little bit on, I will briefly mention liraglutide, but I will mostly focus on the newer agents, semaglutide and tirzepatide, in this section of the talk. So GLP-1 receptor agonists for weight management, as I mentioned, include liraglutide, which has the brand name Saxenda, and semaglutide, which has the brand name Wegovy, when used for patients with obesity and without type 2 diabetes. Liraglutide is a once daily injection titrated weekly to a maximum dose of 3 milligrams. And semaglutide is a once weekly injection titrated monthly to a maximum dose of 2.4 milligrams. Now, this is sort of the recommended dosing and titration. Of course, if patients are having side effects or if they're having, significant weight loss significant weight loss at a lower dose, it is reasonable to continue a lower dose for an extended period of time. We have seen a lot of results over the past 2 years on the role of semaglutide 2.4 milligrams among patients with obesity. This has been studied in a series of trials referred to this as the STEP trial. The STEP 1 trial was the main clinical study looking at semaglutide 2.4 milligrams in patients with obesity and without type 2 diabetes. In this study, it was a randomized trial where about 2,000 patients were randomized to either placebo or semaglutide 2.4 milligrams. And what we see is that at 68 weeks, the semaglutide treated group had achieved an average weight loss of 15%. And so up until this point, there had been no anti-obesity medication that came even close to this degree of weight loss effectiveness. And then if you look at thresholds of weight loss, about a third of individuals lost over 20% of their body weight. So this was sort of the first signal that pharmacotherapeutic options could, potentially bridge the gap between lifestyle change and, bariatric surgery, right? We're getting closer to weight loss that we see with surgical intervention. The STEP 2 trial evaluated the weight loss effectiveness of 2 doses of semaglutide, 1.0 milligram, which was the maximum dose for type 2 diabetes at that time, and then semaglutide 2.4 milligrams. And in contrast to STEP 1, this trial included patients with obesity and type 2 diabetes. And here we see that mean weight loss among patients treated with semaglutide 2.4 milligrams who had obesity and type 2 diabetes achieved an average of about 10% weight loss. And so, this is about 5% lower, right? They're not losing as much weight as we see with patients with obesity and without type 2 diabetes. And this is fairly consistent with findings in other trials for anti-obesity medications for some reason, and I don't think we really have a good explanation as to why, but patients with type 2 diabetes tend to lose less weight when treated with an anti-obesity medication. I think this is important to kind of have in your mind when counseling patients at the onset of therapy, because of course, individuals want to know what to expect in terms of side effects and weight loss effectiveness. We know that weight regain occurs with discontinuation of semaglutide, which is not, that's what we see with all anti-obesity medications. These are data from the STEP 4 trial where all patients were treated with semaglutide for a run-in period. And then at 20 weeks, they were randomized to either placebo or continued use of semaglutide. They were then followed for a total of 68 weeks. And at that point in time, the patients that had been randomized to placebo had regained about 50% of the body weight that they had initially lost. And based on kind of the trend of the line, you can, predict that they're probably going to continue to gain weight. Those treated with semaglutide continued to lose weight during the study period. And so I think, this really highlights the fact that obesity is a lifelong chronic condition, and that similar to our treatment of other chronic conditions, we should be thinking about, the need for ongoing and long-term therapy. If we think about treating patients with hypertension, for example, we would not predict or expect that somebody who reaches a goal blood pressure with use of an antihypertensive agent would be able to maintain that blood pressure if the agent was removed. Now, I will say one other thing here is that there are some patients who are not going to want to continue on a medication long-term. I think we can counsel them on these findings and the fact that we see in trials that most people regain weight. I've had a few patients who have been able to maintain weight off medications if they have had sort of a substantial change in the factors that were contributing to their obesity. So somebody has a highly stressful job, no control over their food environment, working, shift work, and then suddenly retires. Well, maybe now their circumstances are so different that they will be able to maintain their medication off or maintain their weight off the medication. I think these are all things that can kind of be considered as part of patient-centered obesity treatment. We know from the STEP 5 trial that these medications are effective long-term. This trial studied weight maintenance out to 104 weeks. We're seeing growing evidence of the cardiovascular benefit of semaglutide. These are results from the SELECT trial, which was recently published. This was a very large trial of 17,000 patients across 41 countries. Patients had a BMI of 27. They had cardiovascular disease, but did not have type 2 diabetes. I will note that I think about 2/3 of participants did have prediabetes, so there was some, degree of baseline dysglycemia. Patients were randomized to either semaglutide or placebo and followed for 5 years. The primary endpoint was a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And what we see is that at 5 years, there was a 20% reduction in major adverse cardiovascular events among semaglutide-treated individuals. These findings are similar or consistent with what we saw in the SUSTAIN-6 trial, which looked at cardiovascular outcomes among patients with type 2 diabetes treated with semaglutide. Jackie, it looks like you are maybe going to ask a question.
Yes, I was gonna say there was a question in the chat. Since medication adherence can be an issue, how do you restart dosing if missed doses for more than 2 weeks? Where they left off, or do you start back at the beginning dose?
Yeah, that's a really good question. I think it's probably depends on a couple of things. One is what dose were they at? If they were at, 0.5, if they hadn't reached the full dose of semaglutide, 2.4, I might consider starting them back at 0.5 if they've been off, for 3 weeks, something like that. But generally, I would say after 2 weeks of missed doses, I'm starting them back at the beginning of their titration. Sometimes we're increasing the titration a bit more quickly, so maybe going up after 2 or 3 weeks if they're not having any side effects. But in my experience, patients have been having fairly significant GI side effects with the higher doses, so just doing what we can to mitigate that. And then these are data from the FLOW trial, not yet published. The trial was actually stopped early because of the beneficial findings of semaglutide 1.0 milligrams among patients with chronic kidney disease. So I think we can expect to see this published hopefully within, sometime early in the new year. Despite, all the benefits, there are some contraindications, warnings, and precautions regarding semaglutide use, and these really extend more broadly to the full class of GLP-1 receptor agonists. There is this black box warning that semaglutide causes thyroid C-cell tumors. This is based more on theoretical data, rodent data. It has not been observed in humans, but nevertheless, we do not want to use semaglutide or any GLP-1 in a patient with medullary thyroid carcinoma or a family or personal history of MEN2. I think if patients are, if they don't, in the absence of these conditions, and if they're raising concern that the medication is going to increase their risk of thyroid cancer, I think you can offer reassurance. I think it's also useful to kind of point to the fact that obesity in and of itself increases the risk for multiple cancer types. And so weight loss will support, reduction in their risk or of many cancers. These medications are also contraindicated in pregnancy and breastfeeding. Semaglutide or GLP-1 should be avoided in patients with a history of acute pancreatitis, acute gallbladder disease. There is the risk for hypoglycemia, particularly in patients who have treatment or are on treatment with insulin or oral anti-hyperglycemic agents such as sulfonylureas. There is the risk of acute kidney injury, which is probably attributable to dehydration due to poor PO intake. Increased heart rate, there is the potential, and again, this is more of a theoretical risk for suicidal behavior or ideation, but obviously counseling patients before they start any anti-obesity medication that has central mechanism of action, that they want to pay attention to their mood and obviously stop the medication and seek help if they're having any thoughts of self-harm or worsening mood. And then there's a concern about diabetic retinopathy. There is, a risk of retinopathy among certain patients. These are typically patients with baseline type 2 diabetes who are on insulin and who have suboptimal glycemic control at baseline. The most common side effects that we see with GLP-1s and the dual agonists, which we'll talk about in the next slides, tirzepatide, are GI side effects: nausea, vomiting, diarrhea, headache, abdominal pain, and constipation. I think there's some data that these side effects are more pronounced in men than women. And I will say I practice clinically at the VA where my patients are predominantly men. And I would say that anecdotally, that seems on point, that I'm seeing more of these side effects reported in men as compared to women. I don't know if anybody has had similar experiences. But what I will say is that, we commonly counsel patients that GI side effects can occur with new medications. The degree to which these side effects occur with GLP-1s, I think, is much more pronounced. And so you really want to make sure that patients know that they may be having serious side effects, that limit their ability to go to work, to leave the home, etc. that they typically go away if patients can sort of endure the side effects in the near term, maintain good hydration, that they typically go away, and that the side effects can be mitigated by going up more gradually on the dose of the medication. So if I have somebody who's having side effects during the titration period, we generally hold them at that current dose until the side effects resolve. Tirzepatide, I'm sure many of you have seen in the news that this medication was just approved last week for treatment of weight management. I'm just going to peek in the chat because I see.
Yeah, I was going to say, one before you move on, since it relates to the last topic, do you have any evidence of Zofran or B12 for managing those longer term side effects?
I have used Zofran for managing the nausea and vomiting. I have not used B12. I have not seen any evidence for that, but I know, of course, like there's sort of the compounding, which we'll talk about, probably not recommended, but there are groups that are doing compounding of semaglutide with B12 potentially to mitigate the side effects. But again, I don't think that is evidence-based. The Zofran, I think, is reasonable to use in the short term. Same with loperamide for diarrhea. So tirzepatide is a dual GIP GLP-1 receptor agonist. So it has a novel mechanism of action. We don't have any medications like this to date. It was FDA approved for the treatment of type 2 diabetes in 2022. And again, it's acting at both of these receptors. It is started at a dose of 2.5 milligrams and titrated once monthly to a maximum dose of 15 milligrams. And I guess I'll mention here that, this slide is showing tirzepatide as Mounjaro, which is the name used for type 2 diabetes. Zeptide is the name of tirzepatide for weight management. It has similar dosing, which is different than what we see between semaglutide as Ozempic for type 2 diabetes and semaglutide as Wegovy for patients with obesity. And tirzepatide, these trial results show us that we're only getting more effective in pharmacotherapeutic management of obesity. These are results from the SURMOUNT-1 trial. This was an RCT of about 2,500 patients, BMI of 30 or 27 with weight-related conditions in the absence of type 2 diabetes. I will say, and I think this is very relevant, that the mean BMI among trial participants was much higher than, the eligibility criteria. So the mean BMI was 38. And when we look at the weight change outcomes and think about how we're going to use this medication in our own clinical practice, I think this is very relevant. The medication, as you can see, has significant weight loss effectiveness. At a dose of 15 milligrams, patients are losing 21% of their body weight on average. And when we look at, these clinically relevant targets, 5, 10, 15, 20, and 25% body weight loss, 70% of patients are losing over 15% of their body weight at the maximum dose. 36% are achieving over 25% body weight loss at the maximum dose. And so, when it was FDA approved, it sort of strikes me as a little bit odd that we've now approved this medication that is so profoundly effective for weight loss, and approved it for use among patients with a BMI of 27 and comorbidities. I would probably avoid use of the medication in that patient population just due to risk of, underweight status, promoting underweight status, and sort of potential harms related to that degree of weight loss. Similar to what we saw with the STEP 2 trial, when we look at tirzepatide among people with obesity and type 2 diabetes, this is the SURMOUNT-2 trial, we see that weight loss on average is lower among patients treated with maximum dose tirzepatide who have type 2 diabetes compared to those who have obesity without type 2 diabetes. In this patient population with diabetes, average weight loss was 15.7%. And the graph on the right shows patients' achievement of these clinically relevant thresholds with now, only 40%. I shouldn't say only 40% because that's still remarkable, but 40% of patients, 48% of patients achieving over 15% body weight loss at the maximum dose. So we are really in an exciting phase for medical weight management, where we have newer agents, semaglutide 2.4 milligrams and tirzepatide 15 milligrams, bringing us closer to the outcomes that we see with bariatric surgery. And, it's beyond the scope of today's talk to go into detail on or to really discuss these medications that are on the horizon. But you can see that we have medications in various phases of clinical trials, such as retatrutide, that are going to approximate a mean weight loss of 25%. Any questions on that before I kind of go on to the next section of the talk? Let's see. So I think this is good. You mentioned a danger in too much weight loss too fast. I have heard that it can affect lipoproteins. Is that why? What is too fast, too much? If I said too fast, I don't think I meant to say too fast. I'm not particularly concerned about the rate of weight loss. People can lose a lot of weight when they have a change that's substantial relative to their baseline. I think I was commenting on the degree of weight loss in a patient with a low BMI. So if somebody has a BMI of 27 or even 30, putting them on a medication that has an average weight loss of 21%, such as tirzepatide, might have harms. And that patient, it's not to say that you should never do that, but I think that there's probably a reason for careful consideration of risks and benefits, and then monitoring the patient to make sure that, they're not having adverse harms related to their degree of weight loss. If weight loss in excess is concerned with lower BMI, wouldn't you just not increase to the maximum dose? Yeah, so I think that that's very reasonable. So what would you monitor? I think I would monitor their degree of weight loss, right? So how much weight loss needs to be achieved and to reduce the comorbidities. So going back to that slide, showing resolution of comorbidities with various degrees of weight loss, I think focusing on 5%, 10%, obviously developing a patient-centered goal. Where are they aiming to head? And then encouraging weight maintenance when the patient has resolved their comorbidities, right? I think sometimes people think they need to achieve a normal BMI, which again is not the goal and can have potential harms, including, weakness, sarcopenia, things like that. What long-term ramifications of chronic use of these meds has been reported? Any information past year and any mental health issues? And is the cost of meds sustainable? Yeah, all really good questions. So long-term ramifications, I don't think we know. I mean, I think we know from the use of GLP-1s for the past several decades in patients with type 2 diabetes that the medications are safe long-term. I don't think we have data for GLP-1s in patients with obesity beyond, I guess, past 5 years if we're thinking about SELECT-2. And then there are concerns about, patients' mental health and, this risk of suicidal ideation, which I think is being investigated. But at this point, there's nothing conclusive. And is the cost of meds sustainable? I think at the current, with the current prevalence of obesity and the current cost of the medications, which we'll touch on in the subsequent slides, I don't think it's sustainable. And so we'll definitely talk about that in subsequent slides. Any labs or other things that should be monitored? Yes, that's a really good question. So I think monitoring for, again, it depends on the patient, it depends on their baseline medications and their baseline conditions. So I would say, particularly as we start using these medications, more use of semaglutide if it's ever available and it has improved coverage, and certainly with tirzepatide, if a patient has type 2 diabetes and they're on medications that can cause hypoglycemia, or if they are on antihypertensive agents, I think close monitoring of blood pressure and blood sugar is imperative. I can imagine, I think primary care in general is wildly unprepared for having access to a medication that can support 25% body weight loss, because we really don't have the infrastructure in place to closely monitor patients' blood sugar levels in the case of type 2 diabetes, or perhaps more of a risk, blood pressure levels in a patient with hypertension on multiple agents. And so I think we're going to have to do a really good job of giving our patients anticipatory guidance and permission to hold meds if they're having signs or symptoms of hypotension or hypoglycemia. Okay, so for the sake of time, I will kind of go through these slides fairly quickly. So, challenges to use of injectable anti-obesity medications include limited insurance coverage, high out-of-pocket costs for the drugs, and then drug shortages. So this slide, these are data from a survey done by Virta Health. And I think what's interesting here is just, we know that these medications are not covered in part due to their cost. And this fact strikes me in particular, which is that a typical employer's drug spending could increase by more than 50% if half of employees who are eligible for Wegovy were to take it. So, there's certainly long-term benefits of the medication, but in the near term, I just don't think that the price point of these medications is sustainable for health systems without dramatic increases in member premiums, or other strategies to kind of, offset the cost. These are two resources that can sort of help you navigate the limited insurance coverage. The first is referenced at the bottom of the slide. This is a resource developed by MCT2D that sort of walks you through preferred agents for the various health plans, private health plans in Michigan. And then the slide on the right can save you time. If you do not know what medications are covered by your patient's health plan, have them do the work. I don't think that we have, for most of us in our primary care clinics, we don't have the bandwidth to determine what medications are covered. And so I think having some worksheet like this to have patients call and find out the information, perhaps in advance of a visit, would make a lot of sense. Without insurance coverage, these medications are really expensive. Wegovy has a price point of somewhere around $1,200 or $1,300. Interestingly, tirzepatide, which was approved last week, it's not yet available, but it has an anticipated list price of about 20% lower than semaglutide. So it'll be really interesting to see what happens in the coming months with semaglutide's price point. Drug shortages, I think we're all aware that our patients are having trouble accessing both semaglutide as Wegovy and semaglutide as Ozempic. As a result, patients are seeking compounded semaglutide. And I think it's worth sort of recognizing that actually compounding is legal when drugs are on shortage. So these compounding pharmacies are not doing anything that is illegal. However, there are still safety concerns related to unauthorized use of, salt versus base forms of semaglutide. And I think the general guidance is to avoid use of compounded semaglutide because of the safety concerns. However, we all know that we're going to have patients that do their own thing. They want to get the drug. They're going to pursue compounded peptides through these pharmacies. And so at a minimum, you can direct them to this FDA site so that they can be sure that they are choosing a compounding pharmacy that is meeting FDA regulations. Now, we are sort of in this, GLP-1 or dual agonist centric phase of obesity medicine. And we've kind of created this narrative where the older medications have failed, the newer medications are going to save the day. But the reality is there is a role for older anti-obesity medications and patient-centered obesity treatment, that this role relates in part to cost, but also in part to patient factors. And I'll touch on that slightly. So to reiterate, there's no one size fits all obesity treatment, that older medications may actually be ideal for some patients. So this slide shows the FDA approved weight loss medications that have approval for long-term use, meaning that they're approved for longer than 12 weeks. We do know that phentermine, which is our oldest anti-obesity medication, approved way back in 1959, has an FDA approval for short-term use, less than 12 weeks. And so that's why it's not shown on this slide. I will discuss phentermine separately on subsequent slides. These medications have complicated mechanisms of action, and with the exception of orlistat, they all work in the brain in a variety of ways. They work to reduce appetite or reduce hunger. They reduce cravings. They reduce leptin resistance, with leptin being the primary satiety hormone, and they can increase energy expenditure. On average, older anti-obesity medications are less effective than the newer medications. However, as with all treatments for obesity, there are wide variations in individual patient outcomes, and all anti-obesity medications can support at least 5 and 10% body weight loss among some patients. So if we look here at the slide, there's just a comparison of weight loss among all of the agents. I guess I included phentermine here as well. And as an example, if you look at phentermine topiramate, which has the brand name of Qsymia, you see that 70% of patients achieve at least 5% body weight loss, and about half of patients achieve at least 10% body weight loss. So it is not true that we don't have medications that work, or that we haven't had medications that work. We actually have. We've just completely underutilized them, and so we have not realized their population level benefit. I will go ahead.
There is a question in the chat, Dr. Griauzde. Is there any value in jump-starting patients with these medications for 3 to 6 months, like limiting the cost long-term, but potentially gaining health benefits for type 2 diabetes and hypertension and cardiovascular disease? How long needed to take medications and receive benefits, but keeping costs down?
Is that specific to GLP-1s? Is that question, or just all of them, jump-starting with these medications?
Not sure from the question. Dr. Carlson, if you can, GLP-1s.
GLP-1s. So first of all, it takes like 5 months to get to the maximum dose that patients are most likely going to regain. So I feel like this idea of jump starting is tricky, because if we take away the medication, most patients will regain the weight. And even if there are health benefits, and we can all point to studies showing that there's health benefits of weight loss at any point, even if people subsequently regain. But I think from like a patient standpoint, that is just, emotionally very difficult. If someone wants to lose weight, they're given a tool to lose weight, and then it's taken away. It's really challenging. My preferred approach is honestly to start with one of the older medications, because they can work in a lot of patients, and then step up therapy as needed, so that we know that by the time we've reached use of a GLP-1, we really have tried everything else, and that this is, the best treatment for the patient, assuming they, tolerate and desire to continue that medication. Does that answer the question?
Yes, thank you.
Okay, thank you. Now, I just want to talk about phentermine as a monotherapy. We know phentermine is approved for long-term use when it is co-prescribed in sort of the fixed combination phentermine topiramate, brand name Qsymia tablet. Phentermine monotherapy, as I mentioned, has been around since 1959. It wasn't subject to the same FDA sort of requirements as the more recent medications. And so because of that, and because it's sort of a stimulant, it got lumped in with other stimulant medications. And so it is a Schedule 4 controlled substance. It does not have any evidence of potential for abuse or addiction. And it is only FDA approved for 12 weeks because it's never been studied for longer duration. I will say there are clinical trials that are going on now to look at the long-term use of phentermine. But what we can see in sort of observational EHR data is that short-term use of phentermine, similar to what we see with other anti-obesity medications, does not result in sustained weight loss. So this dark red bar, patients at 6 months have lost about 3% of their body weight. When the medication is continued or discontinued, and they remain off the medication, by 24 months, the patient has regained most of the lost weight. In contrast, if you look at the dark teal bar on the far right, these are patients who are treated with continuous phentermine up to 24 months, and their mean weight loss is minus 7.5% at that time point. We do know, again, that discontinuation of phentermine leads to weight regain, and that based on sort of these observational data, phentermine appears to be effective and safe for long-term use. There are variations in state prescribing laws, and that we do need to document off-label use of phentermine. We can consider patients' comorbidities. And so for the sake of time, I won't go into detail, but I think it's always nice to address two conditions with one agent. For example, migraines, we might consider use of phentermine and topiramate, which can be used for migraines. I will say that Dr. Oshman gave a talk on anti-obesity medications maybe a year or so ago. I've put the link here, so if you want more information on these older agents, you can go to this link. And then I have some more information in the additional slide section of this talk. I do have a case example. We are almost at the 50-minute mark. Should I go through the case example?
Yeah, I think since people have been asking questions throughout the presentation, it'd be okay if we don't have the full 10 minutes at the end. So yeah, go ahead, Dr. Griauzde.
Okay, perfect. So this is Mr. C. He's a 65-year-old male with obesity. His BMI is 51, and he has type 2 diabetes. He's treated with glipizide with an A1C of 7.5, and he also has a history of hypertension. He has actually already, he's seeing me for medical weight management, and he's already undergone bariatric surgery. His highest pre-surgical weight was 385. He lost about 100 pounds, but then had weight regain and now is just about 30 pounds below his pre-surgical weight. When asked about barriers, so I kind of chose this case because I think it highlights the complexity of providing patient-centered obesity treatment, right? He identifies a lot of barriers: shame, a sense that he's disappointing others. He has, a diet that's high in processed carbs. He's going to fast food quite frequently. He is struggling with high levels of hunger and, trying his best to eat multiple small meals throughout the day to manage his high hunger levels. So before starting an anti-obesity medication, we need to address these other issues. And, I think with what strikes me when working with patients with obesity is that they feel, and it's not surprising with how, we as a health system have treated obesity over the past decades, they feel that this is their fault. And so I think it's super important to address and minimize shame and take sort of the blame away from the patient, right? Patients don't come to us with poorly controlled blood pressure saying that they feel like they're disappointing us. And so with this patient, I sort of said, listen, if you're not reaching your weight loss goal, that's not your fault. That's my job to help you medically manage this chronic condition. And that brought him a huge sense of relief. We stopped obesogenic treatments. He's on glipizide. I would say I almost never start an anti-obesity medication without trying to reduce use of obesogenic agents for type 2 diabetes, just because we have so many agents now that can promote weight loss. And there's really little reason to try not to reduce these obesogenic agents. And then we need to support lifestyle change. So he was already trying a low-fat diet. Generally, if patients are trying a low-fat diet and it's not working for them, I try to pivot to a lower carb approach. And obviously this aligns with sort of the MCT2D mission of carb restriction to promote weight loss. We initiated and titrated liraglutide. At the point when I was seeing him, we didn't have semaglutide. So we started with liraglutide and titrated to its maximum dose. When he came back 3 months later, he was actually down 16% of his body weight. And most importantly, he had improved mood, improved self-confidence. He had actually started a job and he had improved mobility. He wanted to lose additional weight. And so we decided to switch him to semaglutide as Wegovy. This slide is here for your reference. I'm not going to go into detail, but basically there is some guidance on how to switch between these weekly to daily or daily to weekly agents. And when I saw him back 6 months later, he was now down 24% of his body weight. He was enjoying his lower carb eating pattern. He liked the foods, but he did identify cost as a barrier to dietary adherence. I tend to use this low carb for any budget reference, which is noted on the bottom of the slide. It's a free PDF. And so we talked a lot about how we could support his adherence to the low carb eating pattern. And I will just end by saying that, you know, we all have knowledge gaps in obesity treatment. We were not taught to treat obesity during our training. There are a growing number of opportunities to fill these gaps. I will say I did the ABOM certification, and I found this to be invaluable. And there are additional training opportunities for NPs, PAs, and pharmacists. And I will end. I don't need to do my slide. We just talked about all that. So I'll end here and ask for questions. Any questions, or does anybody have any like case examples or experiences that you want to share? Good question. So when does bariatric surgery fit in? After how long, with meds or lifestyle? So I would say that, you know, of course, patients should try lifestyle modification before undergoing bariatric surgery, and that is actually part of the, you know, pre-bariatric surgery evaluation process. I tend to bring up bariatric surgery for patients who meet eligibility criteria. And I practice in the VA. I think maybe there's a shift to lower BMI, but I think we're still at BMI of 35 with comorbidities or BMI of 40. For those patients, if they meet eligibility for bariatric surgery, I am bringing it up, making sure that they're aware that it's a treatment option. Many patients aren't ready to consider the option. Some people want to kind of be referred on to get more information. But I do think it's important to make sure patients know that it is an option. For some patients, they're surprised to learn that they're even eligible. And I think that's kind of a light bulb moment where maybe they decide, oh yeah, I do want to take my weight seriously and let's try meds and then maybe consider this in the future. Let's see.
There was one, Dr. Griauzde, when insurance no longer covers due to normal BMI, do you recommend weaning down or just discontinuing?
So this is a tricky, so again, I practice in the VA, so I haven't encountered this issue. Technically, the medication should be covered as a maintenance drug, but are people finding that insurance is cutting off coverage at a normal BMI? I guess maybe the question is sort of, so the medication should be continued. I think for patients that that have the insurance for whatever reason stop coverage, we obviously want to support them, and then maybe we're kind of scrambling to use some of the older anti-obesity medications, some off-label use. But really, we don't want to stop the medication when a patient reaches a normal BMI. Now, if a patient is underweight, or if you have concerns that there is an eating disorder that has developed, that's, that can occur. The process of losing weight can sort of be a thrilling experience. Patients want to continue losing weight even when they've reached a healthy weight and have resolved their comorbidities. I think that's a different issue. And there's a need to have a discussion with the patient about maintaining rather than continuing to lose. I don't know if I answered the question, but feel free to jump in if I didn't. So thank you. My husband had been 3 weeks without his Ozempic, and next year's insurance will not cover the same anti-obesity med. He has diabetes, and Ozempic had been helpful. That's awful. I'm sorry to hear that.
A couple other questions. Someone said that they had a patient aspirate during a colonoscopy taking Mounjaro. Are you stopping GLP-1s before colonoscopies? This has been coming up. I don't know what somebody else can jump in if you know what the current guidance is. I know that I had heard, we were stopping. I feel like I've heard people say stopping 2 weeks before, but somebody else jump in if I'm wrong about that.
I can answer this. So, they recommend stopping at the last dose, the American Anesthesiology Association, and it's based off of, especially if patients have acid reflux or symptoms on the GLP-1, they recommend stopping for any procedure or elective surgery. If there's an emergency surgery, it's something that they can deal with as long as they know the patient is on a GLP-1. I just copied and pasted their consensus guidelines. But if they don't have any symptoms or side effects associated with the GLP-1, they find that it's just a theoretical concern, but it's not something that comes up often. But clearly it happened to one of your patients.
Anything else in the couple of minutes we have left?
I just wanted to highlight that if BMI normalizes, insurances still should cover the GLP-1s. If that doesn't happen, so patients should have regular check-ins. So sometimes an insurance won't cover an anti-obesity medication because the patient hasn't been seen and hasn't had a weight. That is something that comes up a lot. It's not necessarily because it's a reduced BMI. If it's because of a reduced BMI, that's something I personally would like to know about, and I would like to advocate on behalf of our patients, because the evidence shows that people regain the weight, and that is honestly abusive to our patients. And I don't think that's something that should happen. So if there are cases where that happens, please let us know.
Jonathan, can you answer the question from Mary in the chat, and I'll answer the last question. How do you decide on a % weight loss goal for patients? I would say that is tricky. It involves shared decision making. So I think that when I have a patient come to me, just from a practical standpoint, I'm always asking them what their goal is. Because I see veterans, they all have a goal that's like their 18-year-old body weight when they entered the military, which is maybe 100 pounds down from where they are. But so it's nice to get a number from the patient. What do they want to achieve? But then sort of backing out and saying why. What do they want to be able to do that they can't currently do, or how do they want to be able to feel? And then sort of having those non-scale sort of goals considered in conjunction with the absolute weight that the patient wants to achieve going forward. And then there's sort of the medical perspective, which is how much weight does the patient need to lose to prevent or resolve comorbidities? If a patient has, a BMI of 30 and they're comfortable at that weight and they have no metabolic concerns, then maybe we're focusing on weight maintenance or just a 5% body weight loss, right? If they're going to continue to gain weight, they will likely develop complications, but focusing on weight maintenance in someone without health complications is always a reasonable goal. Then I look at the patient's comorbidities and think about how much weight might that patient need to lose to resolve comorbidities. And that's where that treat to target slide comes in handy, where, if they have, and it depends what their goal are. Do they want to get off their CPAP machine? Okay, well, maybe we're going to be thinking about 15% body weight loss. Do they want to come off some of their type 2 diabetes medications? Well, then maybe it's 10%. And so I think then it's sort of thinking about the percent body weight loss to resolve or control weight-related conditions, but then obviously contextualizing that within the patient's goals. Does that make sense? And I will say this idea of percent weight loss, I know we're over on time, and I'm just going to say one last thing, which is that it is hard that is our biomarker target. I think it's very appropriate, but it's much harder to, with A1C, for example, we're looking at an absolute number. This patient has A1C below goal, check, move on. With percent weight loss, it is tricky to know what is our starting point. The medical record doesn't calculate percent weight loss for us. So we sort of need to take that step. If we have nurses involved, what came up in my clinic recently is that our nurse didn't know how to calculate percent weight loss. Not her fault. We didn't teach her. And so, there's that extra step involved because the medical record doesn't do it for us. And of course, the starting weight is, needs to be defined. So thank you all. Feel free to reach out if there's any questions. Jackie, I think I can send you the slides and you can circulate them to the group.
Yep, we sent them out during the presentation since there was a request from someone to be able to take notes during it. So Lefa sent them to everyone who's registered.
Oh, amazing. They might not be the most updated slides. So I'm just going to send you, because I'll just send you a new draft. They're probably similar, but great.
Thanks so much, Dr. Griauzde. Thank you all for attending. We really appreciate it.
Thank you.
Bye.
Great.